ยังยุบบุกกันเลยฮะ
party we don't wanna be at. Trying to talk but we can't hear ourselves. Red your lips, I'd rather kiss them right back. With all these people all around, I'm crippled with anxiety, but I'm told it's where I'm supposed to be. You know what? It's kinda crazy cause I really don't mind. And you make it better like that. Don't think we fit in at this party. Everyone's got so much to say. Oh yeah, yeah. When we walked in I said I'm sorry, but now I think that we should stay. Cause I don't care when I'm with my baby, yeah. All the bad things disappear. And you're making me feel like maybe I am somebody. I can deal with the bad nights when I'm with my baby, yeah. Cause I don't care
Norinia. Hello, Brian. สวัสดีครับสวัสดีครับ Brian.
Yeah, good
Yes.
afternoon.
Good afternoon.
Hello,
Turn on your
hello,
turn
Mr.
on your
Bart.
camera, please, Brian. Turn on your camera.
Yeah.
Okay.
Looking now.
Do you finish? Do you finish the presentation of your breakout?
Yes, we are done. Even the
Thank
school.
you so much. Thank
Yes.
you, Brian.
Hi.
Do you
Uh, yes. Of the presenters when we coach, we're not in the room, and we're trying to make sure again with the presenter. So perhaps they will be after this break. We will continue the
Oh,
presentation
okay.
to make sure that
Because
they are in the
yes.
room.
Okay. Because I have upgrade the Zoom meeting for 1,000 participants.
Wow.
Yes, I think maybe this afternoon everything will be okay for the presentation and for the presenter for the East breakout room. I think it's okay for this afternoon, right?
Yes.
Okay, thank you so much. Thank you for your cooperation and your help. If I know all of you, I can't, I can't do my project. Yes, and your student come to join our conference. So many participants from Indonesia, from Philippines. A lot.
Usual.
Yes, a lot. Why a lot? Surprise. Yes, surprise. And this is the first time of my college to do projects like a virtual international conference. And 4 years ago, or maybe 2 years ago, that you come to join with us in Payao province. That is an on-site, right? On-site international conference. That's very nice and fun. And today is for the COVID-19 pandemic. We can't do for the on-site conference. We have to do for the online. And many students interest for my conference. More than 400 presenter for the research and innovation and creative works, and 1,800 for all participants from over the world, right? Around the world.
Yeah. Congratulations,
Amazing.
Mr. Tony. It's very good.
Amazing.
Yes, amazing.
Yes. Next year.
Good
Next year,
afternoon.
come to join me. Next
Online.
year. Okay.
Okay.
No online.
I have
no online.
your students. I have your students in room 7. They were so great presentation, but I don't have DCN students in my room.
Yeah.
Good afternoon ค่ะ
Yeah,
บ้านเรี
I
ยน
have
โนเรี
also
ย
many students from Bangsa University in my room, in room 6, and I like their experimental products.
Thank you.
Yeah,
Okay.
they are mostly pharmacists.
Oh,
They belong to the pharmacy. Yes.
Pharmacy student, right?
Yeah,
Yes,
they have.
pharmacy students. Yes.
Oh my God. Amazing.
And I met some partners also, my old friends, like from Manila University as well.
Yes.
Manila Central University, right?
Yeah,
Okay.
it's very amazing.
Yeah.
Still love the ceremony, opening ceremony session. That was great as usual.
Thank you. And this afternoon, the keynote speaker is very fantastic from the Southern New Hampshire University in United States of America, and from St. Louis University. Norinia, your boss,
Your boss,
Yes,
yeah.
my boss.
It's
Yes.
great.
Yes, Professor Mary Grace come to
Yes.
join. Yes,
Mm-mm.
and will talk about the potential roles of education and clinical professional in a disruptive world. And for the first one is Professor Tony Creighton. She's from America. She will talk about COVID-19 pandemic, ethical,
Hello, Miss Grace.
ethical, and
She's
social
here.
issue.
Miss
Oh,
Grace.
Hello, good
yeah. Hello,
afternoon.
Grace. Hello. Good
Afternoon.
afternoon, Grace. How are you?
Glad to see you finally.
Hello everyone.
Yeah. Hello. Yo. Unfortunately, we can't join in Thailand next
Couldn't
year.
imagine if this is offline.
Right. So
What happened?
I
sorry.
couldn't imagine if this event offline.
Online.
1,000 participants.
Yeah.
But maybe we can record the proceedings so later on they can watch it when the internet connection will be back.
Mm-hmm. That's great. And are you excited for your keynote for the second one of today?
Yes, excited to share.
No, you're a professional. You're a professional. Okay, can I answer the
Yeah, please.
Good afternoon ค่ะ Barry and Grace, Dean Grace. Hi, I'm Donna. Can you see me? Yes. Okay. Dean Grace, Balian, and Noria. Nice to see you today. And thank you for joining us. And Dr. Tony Creighton, are you with us? Good afternoon from Thailand, Dr. Tony.
because we have a problem of the signal from USA, and Dr. Creighton have a video clip with Mr. Tick, technician man. Can you please come to see Mr. Ekachai and talk about the clip video from Tony Creighton?
So we can start from the NC to introduce Dr. Tony Creighton, and then we play the clip, right?
Yes. No. You can't. You. Sorry, Donna.
Yep. This one, the script that we show.
In normal seat.
Hello, students. Hi, students. How are you there?
Hello, student.
Did you really enjoy?
No microphone with student.
Oh no.
They are in a big hall.
My boss, shall we start or?
Yes, sure. You can start from the MC announcement for the CV of Tony Creighton, and then followed by the clip video.
Good afternoon, ladies and gentlemen. I am Thipawan Wenkeo.
I am Antana Rungvilai.
We are third year nursing students from Barom Rajashonani College of Nursing Payao. We are going to begin the second day of our forum. Please ensure that your equipment is set up to properly view the event, and please make sure your microphone is away on mute.
Honorable guests and participants, ladies and gentlemen, good afternoon to everyone, and welcome to the second day of our student forum. In our traditional Thai greeting, I would like to say,
สวัสดีค่ะ Kumusta?
Selamat pagi to all of you. Once again, we are delighted to welcome all participants to our conference. I would like to express our heartfelt gratitude for your presence at this memorable occasion. It is indeed a pleasure to have you all here today.
Honorable guests, ladies and gentlemen, let me introduce our keynote speaker for the day, Dr. Tony Clayton from Southern New Hampshire University, United States of America, to present the topic COVID-19 pandemic, ethical, legal, and social issues.
Let me tell you more about Dr. Tony Clayton. Dr. Tony Clayton is an Associate Dean of Healthcare Administration within the Department of Nursing and Health Professions at New Hampshire University. She has her expertise in healthcare administration and health science. With a passion for developing high-quality curriculum, she provides experience in program and curriculum development, faculty leadership, and accreditation support. Having worked in many healthcare environments, she has applied in-depth knowledge of healthcare delivery system toward operational and strategic initiative. This work includes leading magnet status nursing teams toward the development of lean processes designed to improve the patient experience and delivery of the quality care and services.
And everyone, let's see the clip video from Dr. Tony Clayton.
Good afternoon, colleagues and students from around the world. I'm honored to join you today to speak about COVID-19 and the ethical, legal, and social issues associated with the pandemic. I'm the Executive Director of Health Professions at Southern New Hampshire University, and I also teach healthcare courses. I serve as the Vice Chair for the University Institutional Review Board, and I had the wonderful opportunity to visit Thailand in November 2019, a few months prior to the pandemic. The International Conference on Advancement in Health Sciences, Education, and Professions, held in Bangkok, Thailand, provided a great opportunity for me to network with my peers, which has set the stage for my attendance here today. I was able to visit the college and hospital in Chiang Mai, and I learned from the nurses there about the major health issues impacting the population. We had some great conversations as I toured the hospital and learned about some of the challenges for nursing students. Flying back to the United States, as I reflected on the wonderful new friendships I had met, the furthest thing from my mind was a pandemic. The first reported death was shared by China on January 11, 2020. And then just a few short weeks later, Japan, South Korea, Thailand, and United States reported their first cases. On January 30th, 2020, the World Health Organization declared a global health emergency for only the 6th time in history. Those of us working in healthcare observed the conditions in Italy, where we saw about 800 were infected as of February 28th. On March 11th, the World Health Organization declared the outbreak of a pandemic of worldwide spread and compared it to the 1918 influenza, otherwise known as the Spanish flu, where 50 million were killed. I share these dates with you because they provide a timeline of how quickly our lives can change and how quickly a virus can spread from one part of the world to another. I share because it reveals how collaboration and sharing among the health community might not save some people, but what is learned can save many others. I'll never forget the week of March 10th, where everything from stores to concert events were being canceled. One day, I was attending my nephew's basketball game, and the next, I was quickly stocking up on supplies as I would for a major snowstorm in the Midwest region of the United States. Many people remain in disbelief, while others quickly started stocking up on supplies such as sanitizer, cleaning supplies, and toilet paper. I'll never forget hearing Dr. Anthony state on one of the evening news shows that things will get worse before they get better. And boy, was that a true statement. The pandemic has impacted nursing, public health, and healthcare administration in a variety of ways. The emotional and physical disruption caused by the pandemic has touched students, faculty, and practitioners in our field. The outlook for the next 6 months indicates that recovery will not be soon, as we are starting to see new variants arise. There is uncertainty surrounding efficacy of vaccines, uncertainty around mental health, and uncertainty around sustainability of staffing. There have been minimal relief from COVID burnout and fatigue. However, we continue to be vigilant in our resolve to get through this together to support our patients while also protecting our own families. The middle photo on this slide is my daughter, Kristen, who is an ER nurse working at a 460-bed hospital. She also worked in labor and delivery throughout the pandemic and currently to support the hospital wherever there were needs. She herself contracted COVID in December of 2020, but recovered with minimal impact on her overall health. When I asked her what the worst part was for her and the pandemic so far, she stated it was the anguish of patients who could not have family visit them in the hospital. This was either from hospital restrictions or because other members of their families were fearful of getting sick themselves. The common themes related to the pandemic for nursing students and healthcare leaders alike relate to nursing education, hospital resources, and patient care. Regarding nursing education, colleagues across the globe have shared strategies and experiences through technologies such as Zoom, RingCentral, and WhatsApp. I quickly learned about WhatsApp from my Indonesia colleagues when I was invited to speak with them on one of their COVID-19 events. One issue that impacted many of our students was internet connectivity. First, remote learning was new, and there wasn't a lot of time for teachers to plan. Next, many students, particularly in the United States, went to libraries and coffee shops and other places where they could get internet connection, which allowed them to complete their studies. Finally, unique to nursing students was finding healthcare facilities that would allow students to complete practicums and clinical hours. As we move past the one-year mark in March of 2021, we found that hospitals had reopened, they were ramping up routine surgeries, and for a very brief time, at least in the United States, around May and June, it felt like things were moving to a new normal. In fact, we even had some faculty presentations about adapting to the new normal. But I think we all can agree the new normal is yet to be determined. Regarding hospital resources, from the onset of the pandemic, there were shortages of PPE, ventilators, and beds. This shortage revealed how ill-equipped our facilities were for a pandemic, even though for years we studied the past and knew a pandemic was inevitable and on the horizon. It was only a question of when. Several years ago, when I worked for a large hospital, I was tasked with monitoring the pandemic inventory. There were certainly times where I thought, wow, we have all these supplies, and when are we ever going to use them? The pandemic reserve was examined on a yearly basis, and outdated supplies were replenished. Based on my experience, I imagine that hospitals that were financially sound could afford this type of planning. However, many of our smaller hospitals and clinics were not in the same financial position to be as prepared as some of the others for a pandemic. Physicians and nurses who traveled abroad, studied abroad, and conducted research were current with their information and journal research on pandemics and understood a pandemic was not just a concept. Today, with the variants increasing, hospitals are reaching capacity and barely had time to recover or strategize from the past 18 months. Shortages of beds are becoming the normal and leaving many communities to seek out hospitals for space, regardless of how far they might have to go to get that care. Finally, regarding patient care, nursing professionals and students continue to be faced with the challenges of protecting themselves and family members. Grandparents, parents, children, and infants are not immune to contracting COVID-19, and there is continued fear that people can unknowingly spread the virus. Fatigue and staffing shortages have placed extra burdens on already overburdened healthcare staff, and this includes educators who are working hard to support students and to support faculty in the classroom. Nurses, on the other hand, are still experiencing patients dying alone because family members are too sick to visit or are at risk for contracting COVID-19. Some of the challenges they are facing fit into three categories: ethical, legal, and social. From an ethical perspective, there are concerns of how best to protect patients' rights and how to protect oneself from exposure to COVID-19 and the variants. There is an increase of moral distress of nurses not being able to support patients and families in the best possible ways. Many of you in this room may have had similar feelings and not being able to provide the care that you would normally be able to provide with the right support and the right resources. There is a moral uncertainty also when nurses find themselves balancing two ethical values that are in direct conflict with each other. Other ethical considerations stem from nurses concerned about treatment options. where there's limited data to really verify the amount of risk. And finally, there's anguish when patients have to be turned away because there aren't enough beds. There have been times when ventilators were limited and administrators quickly had to develop policies to determine which patients are prioritized. From a legal perspective, thinking about 2020, there was hope for people waiting for COVID-19 vaccines to be released. Surprisingly, when the vaccines became available around January and February of 2021, not everyone was receptive to getting the vaccination. There were many people who argued that there was not enough evidence of the long-term effects, while others were questioning the religious components of getting a vaccine. Mask and vaccine mandates have led many people to challenge decisions made by hospitals, schools, and businesses. Many people in the United States feel that their freedom and constitutional rights are being infringed upon. And government officials at the state level vary on how they approach the mandates themselves. Overall, misinformation in general about the pandemic has not helped the situation, it has not helped our nurses, and it has not helped our students. Hospitals that are mandating vaccines are losing some of those nursing faculty who are opposed to vaccines. Recruiting and retaining nurses has already been a challenge, and mandates are complicating that situation and concern. Hospital administrators have been working to identify liability and legal ramifications for situations that have no prior precedents set. A variety of surveys have been sent out from universities and healthcare associations to gain the nursing perspective on vaccines. Recent statistics released by the American Nurses Association and the Journal of Clinical Excellence have aligned with the perspectives. Some of those statistics, while they vary based on who's conducting the survey, about 25% of nurses surveyed were wary of the safety and effectiveness of vaccines. And 1 in 8 nurses have not been vaccinated. However, many of my colleagues believe in part the vaccination numbers don't speak to the numbers of nurses that have already survived COVID and are now immune. Mandates by hospitals are complicating staffing needs, and there's an increased alienation of workers on both sides of the vaccination argument. Some additional statistics that I pulled this week indicate the rise in the variant is definitely complicating things for all of us. The average number of coronavirus cases in the United States was nearly 300% higher this past Labor Day weekend. And that was compared to the same time a year ago. The average number of deaths was more than 86% higher compared to the same period in 2020. There were about 1.146 million weekly cases this past weekend compared to under 300,000 last year. And according to Johns Hopkins' latest report, the Delta variant continues to surge across the country. And on September 6th, there were over 73,000 new cases of COVID in the United States. With those statistics in mind, from a social perspective, one challenge that continues to be difficult for everyone is the social isolation between family and friends. On one side of the family, you have members who are fine getting together and willing to take the risk, while you have other members on the opposing side that are following protocols and wanting to be as safe as possible and not willing to take the risk. Weddings, sporting events, birthday parties, travel, and many other social events have mixed messaging and mixed perspectives on attendance. And regarding attendance, how many is the right number to invite? Is 20? Is it 50? Is it 15? When you watch some of the sporting events, you can definitely see that there are crowds of people attending games. I watched a recent news report regarding a local college football team, and there's plans to have a full stadium this weekend. So alienation from family and workers on both sides is really causing fear and more isolation. Geographic restrictions are not consistent across geographical regions, making it difficult to judge when many social events could be rescheduled. Finally, I would say that overall, the coordination of efforts has been complicated, and it's difficult in the United States politically, where you have states with opposing views along party lines. Daily news reports indicate the increasing divide by Americans, particularly now as mandates for vaccines and mandates for masks for going to school or attending events has increased. And conversations with my own family, my coworkers, and my friends support that they aren't just news reports, but that divide for social activity and from a social perspective continues on. Making care more accessible has always been a concern in the United States, and telehealth pre-pandemic had started to increase in popularity by the healthcare community. In July of 2019, studies revealed that over 74% of Americans were unaware of telehealth being an option. From an insurance perspective, many plans did not cover telehealth services. The healthcare community recommended interventions such as patient education, consumer experience, and increasing connectivity. And as a result of the pandemic shutdown in March of 2020, organizations that previously hesitated to move forward with telehealth capabilities quickly realized they had no choice. They had to switch to new technologies and new ways to contact patients who were in lockdown. Ethical, legal, and social considerations of remote care had to be examined, and action was needed to adjust policies to reflect new standards. Some of the legislation passed in response to the pandemic may not necessarily mean a lot to you if you don't live in the United States, but I thought it was still important to provide some of these legal acts and policies, because if you look at the dates, you will see just how quickly the government responded. And many of my colleagues in the healthcare community were just shocked because they had worked for several years to try to address some of the concerns around patient care and telehealth, and particularly to some of our most vulnerable populations which consists of those people who live in remote regions of the United States and also have limited access to have transportation for care. Moving forward, as nurses, students, and educators in healthcare, we will certainly be learning from the past, and we're going to adapt to the current environment, and we continue to shift as those needs present themselves. And we also are planning for the future as we identify common themes surrounding nursing education, hospital resources, and patient care. Many nursing programs around the globe prior to the pandemic realized the importance of students understanding the global needs of our communities and just how quickly we'd need to share our knowledge with the healthcare community for handling health risks. The critical need to collaborate with nurses around the globe was evident since the start of the pandemic. I'm encouraged, and I hope that you are too, that events such as today with the pandemic can bring us together and help unify us in our resolve to strategize and to share best practices as we support each other in the classroom and in the clinical environment. Improvements in technology, as you can see on the screen, with the internet, the phone, computer apps, can only help to support each of us to minimize that physical distance between colleagues. In the United States, many of my colleagues who typically would go into the university to work quickly became remote employees. And so technology really wasn't as relevant to a global connection, but even a connection for ourselves and being able to communicate and find that way to share the information and in the most timely needed fashion. I've appreciated the opportunity to connect with my peers in Thailand, Indonesia, New Zealand, and the United Kingdom. I'm thankful for the opportunity to collaborate and plan for the future. I wish for you to be safe and for you to have the support you need as we all continue to navigate through the pandemic. Thank you very much.
Thank you very much for Dr. Tony Clayton to share us that. I do agree that nowadays, since COVID-19 pandemic influence to our ethical, legal, and social issue, and you are explain us about how its impact, especially for the nursing education. And nowadays, all of us have to change our way for teaching and practicing in nursing, especially when nursing going to practice in the hospital or in the community. We have to change our way of teaching or coaching, especially we need our nursing students safe, and also we want to prevent our patient and the other to save from the COVID. And before we have some time that I like to invite Dr. Tony or Dean Grace to share your idea toward the presentation. Yeah, thank you.
I think Professor Tony Clayton in our room now.
Yes, hi. Thank you.
Yes, thank you very much, Super Dr. Tony.
Yeah, we've
And
actually had thunderstorms and
right, yeah, I
power
know.
outages this week. So I'm so happy. I'm so happy to see everyone. I watched some of the students dancing earlier, and it just really warms my heart to see everyone again.
Yeah, thank you so much for your time. Maybe 1 o'clock in the morning in United States of America, right? Because in Thailand it's one and a half hour in the afternoon, right? Are you sleeping?
Yeah, here it is 2:30 in the morning.
Oh, are you sleeping?
And it's still look bright.
I think you want to go to bed because
I probably will, but yes, I did drink a lot of coffee, but yeah.
Okay. Because of the time difference between Thailand and United States of America for 12 hours. One 1 o'clock in the afternoon in Thailand and 1 o'clock in the morning in United States of America. Thank you very much for your presentation about the COVID-19 and the ethical, legal, and social issue, particular for the effects for nursing education. Yes, and you give me more information about how to cope with the effect of the COVID-19, like nursing education, and how to make sure we can stay safe from the COVID-19, and how we have to resolve the problem after the COVID-19 pandemic is gone, right? Thank you very much. Nice presentation. And I would like to introduce Professor Mary Grace from St. Louis University in Philippines. She's the second keynote speaker. Follow you, right? Professor Mary Grace, can you introduce yourself, please?
Hello, I'm Grace from St. Louis University in the Philippines. So I hope one of these days we can also get connected. Well, your presentation is more or less similar to what we're experiencing in the Philippines, although the situations in the healthcare facilities may be much worse at this time. But we're just so happy that we're all coping, and hopefully we remain safe all the time and that COVID will be gone soon.
Yes, I think in the United States it caught us a little off guard because people started to travel again in June and into July. And really by the beginning of August, the variant really started spreading in the southern United States.
Yeah.
And hospitals there were hospitals, I mean, like hundreds of miles away trying to get bed space. And actually just yesterday, the president announced that they were requiring more vaccines for people and businesses because it's just so rampant right now. If you go in for a heart attack or, another health issue, you could end up dying from something not even COVID related, but there's just not the cases.
And there's a message in chat. I would like to read the message for Dr. Clayton. Fantastic presentation, Dr. Tony Clayton. That was very interesting and has given me a great insight into what is happening over the state. Good luck and stay safe. And another one message is, thank you so much. That was very interesting, Dr. Tony. Yeah, nice. Very nice.
Thank you so much.
Yes. And would you like a cup of coffee?
I would love a cup of coffee. And I really like that we both have the same name. Tony?
Yes, yes. We are the same name. And we also appreciate when I met you and I'm not sure 2 years ago, right, in Bangkok. Yes, for the first conference of the PBRI in Miracle Hotel, right? Yes,
Yes.
right.
And
2019, right? 2019. Yes, this is
yes.
amazing
2019.
one.
Yes,
Thank
no,
you.
2019. So it was, it was really January. So just wasn't back from Thailand, but maybe a month. And going into January is when, just started, hearing about it. And yeah. And actually, I've been, some of your colleagues have attended some of the Southern New Hampshire University Global Summit, and hi to Kate and Jojo if you're out in the hi Kate, hi Jojo.
Yeah, Jojo. Yes, Jojo. She's in Chiang Mai. Yes. Okay. Thank you very much. Yes. Thank you for your time and nice presentations for
Thank you.
yes, for nursing students around the world. We have more than 1,899 nursing students participate in this conference, and now we have presentations for the research work and innovations of the nursing student, and another one is for Thai language Thai language presentations for research and innovation too. Thank you very much. Thank you for your time. Yeah.
Thank you, and good luck, students, and thank you for taking the time today too.
Right, and hope to see you again. Yeah.
Yes, I cannot wait.
Right, and I
wait
would
to
like
go back to Thailand.
and I would like to welcome you to Thailand. Thank you very much.
Thank you, Dr.
Bye-bye.
Thank you, Dr. Tony Creighton, for nice presentation. We received more knowledge from your presentation and apply to nursing student learning during COVID-19 situation.
The next session, we will have a second keynote speaker, Professor Dr. Mary Grace Lacanaria, Dean of School of Nursing, St. Louis University, Philippines, to talk about how to teach and study in a new normal era with COVID-19. Let me tell you more about Professor Dr. Mary Grace Lacanaria. Dr. Mary Grace Lacanaria is the National President of the Associate of Deans of Philippines College of Nursing and a member of the Technical Committee in Nursing Education of the Commission of Higher Education. She is the Academic Dean of St. Louis University School of Nursing, which is recognized by the Philippines Commission of Higher Education at a Center of Excellence in Nursing Education and as an autonomous university, given her local and national leadership in nursing. Dr. Lacanaria is a strong advocate of quality nursing education, having served as a resource person by Commission on Higher Education and Associate of Deans of Philippines College of Nursing, in crafting various policy and programs related to nursing education in the Philippines. She is also the lead in crafting the qualification and competency of nurse educator for the Nursing Career Progression Program and a member of Technical Working Group for the Nursing Bill on the new Philippine Nursing Practice Act, which are both programs by the Professional Regulatory Board of Nursing. She is a nursing consultant on curriculum development, a prolific researcher, and a strong advocate of the quality of life of Filipino nurses. Everyone, please welcome Dr. Mary Grace Lacanaria.
afternoon, everyone. Good evening and good morning in other parts of the world. So let me share my slides with you. Okay. Okay, I'd like to go back to the first slide. Okay. So the topic assigned to me, can you see the slides from here, from where you are?
Yes, ma'am.
Okay. Is teaching and studying in the new normal. Of course, we're referring to the current COVID pandemic situation right now. And I'd like to start by defining what the new normal is. Several references would say that the new normal is a new way of thinking about, deciding on, and doing our usual affairs with an invigorated sense to remain healthy. Which means that safety is now one of the major considerations as we teach and learn. New normal also says that this requires emerging behaviors, situations, and limited public health standards that will be institutionalized in common or routine practices. So while we continue to teach and learn, there has to be certain adjustments that will have to be made. And according to UNESCO, which is the United Nations Educational, Scientific, and Cultural Organization, it presented an education in post-COVID world. And there are 9 ideas for public action as proposed by the International Commission on Futures of Education. And among those that I think are very critical as part of the discussion this afternoon are 1, education as a common good. We need to continue the role of higher education institutions to teach and for the learners to learn. We cannot simply stop and wait for the pandemic to stop before we can proceed with education. Teaching and teacher collaboration is also emphasized, which means that there need to be some paradigm shift to be done. There need to be some rethinking about how best to teach, given the limitations provided for by the pandemic. And teacher collaboration is one of the welcome opportunity as we do team teaching, as we share our knowledge together, and as we bring forward quality nursing education. Student participation, which is referred to as student engagement and active learning, is also very critical. At this point in time, without the physical presence of the teacher and the students in the classroom, a lot has to be done in terms of adjustments. Social spaces to transform education. We need to create an idea of teaching learning outside of the 4 walls of the classroom. That there are a lot of factors now that influences learning. Learning can happen at home, and teachers can work at the confines of their houses. But at the same time, teachers and school administrators should also consider that aside from several opportunities to learn outside of the universities, there are also several factors affecting the performance of students in their houses as influenced by other tasks they have to do and other possible considerations. UNESCO also emphasized scientific literacy within the curriculum. Schools should teach students and learners to search facts and information, not just hearsay, to understand data and knowledge and use this as basis to make informed decisions about their life and about their learning. And the 6th, which I think is very important, is the right to education. Pandemic has brought us to extraordinary circumstances, and we know that the learners are not similarly situated. Okay? And therefore, schools have to make several adjustments in line with this. And this is through equity. Now, equity, as shown in the picture here, is compared with equality. in higher education institutions, we don't just simply provide the same opportunities, the same learning resources to all the students. It is critical with the new normal that we need to understand the needs of the students and make the adjustments for that. Now, if I may speak in terms of our experiences in the Philippines, particularly at St. Louis University, we have students coming from the different parts of the country. And because St. Louis University is in the Cordilleras, a lot of mountainous areas, some of our students doesn't even have signal for the cell phones. How then can they participate and join online learning activities? Therefore, what we did is to have two modalities at the start of the pandemic. We had students who had strong internet connectivity to be engaged in online learning, and students with no or very limited or very intermittent internet connection will have to learn through correspondence-based learning, where we printed the learning materials and modules. We save all the digital resources in a USB and mailed it to them. Okay? But of course, there are challenges as well. Part of the adjustments that we did, which I think are extra efforts that schools are doing, is to reach out to them through other means of communication, because they also deserve to interact with their teachers, although done remotely, but in different ways of doing it. So new normal means that we need to understand the needs of our learners. We need to provide extra services and opportunities so that all of them will have to learn properly. Okay. The World Health Organization, on the other hand, issued a manual on the global strategic directions for nursing and midwifery for the next 5 years, from 2021 to 2025. And it emphasized that nursing and midwifery education should highlight on the use of innovative, resilient, and effective methods of learning. Not everything that we do prior to the pandemic will be effective at the moment, and therefore we need to innovate. We need to be creative. Educate with cross-cutting competencies in interprofessional, team-based, and culturally appropriate care and the use of digital technology. Now, techno-intelligence skills is now highlighted aside from teamwork, aside from interprofessional education. And teachers and schools will have to develop effective learning designs, digital accessibility, appropriate assessment and tailored learning, and support for faculty to design and deliver digital learning. Faculty capability building is one of the major programs that higher education institutions should invest on to make sure that learning in the digital world, and given the restrictions of the COVID pandemic, can still be achieved effectively. Now, in the Philippines, at the start of the pandemic in March 2020, it started crafting policies and guidelines, and eventually it issued the guidelines on the implementation of flexible learning, which the regulatory body in the Philippines think would be appropriate. And so they said that the nursing curriculum will have to be implemented using flexible alternative learning, and that higher education institutions must be COVID resilient, meaning they need to continue performing their roles to deliver instruction to the students. Now, even Einstein would say that we cannot solve our problems with the same thinking we used when we created them. With the changes, aside from the trends and the challenges, we need to readily make adjustments. And that is what we're expected to do in the new normal. Now, how do we define flexible learning? It is the design and delivery of programs, courses, and learning interventions that address learners' unique needs in terms of place, process, and products of learning. Okay? Take note, it emphasizes the learner's unique needs. It may use digital and non-digital technology. It may cover residential, which is face-to-face or in-person, if and when health and safety protocols are observed and if it is safe. And non-residential mode, this is with the use of online modality or correspondence-based modality. And this is what we call, therefore, the possible implementation of blended learning or simply distance learning, depending on the circumstances of the specific regions. And in the Philippines, because of the flexible learning approach, higher education institutions were encouraged to make some curricular restructuring as needed, meaning the usual program of study or subjects that has to be offered every semester may be moved. In the early parts of the COVID pandemic, it was recommended that we first start with the lecture and theory subjects and wait for the practicum subjects to be offered at a later time. But then again, some higher education still proceeded, offering clinical courses, but implemented alternative learning modalities, calibrating learning outcomes, meaning we only need to identify essential competencies. Those that are not too essential or topics and competencies that may not be too basic at this point in time can be transferred at a later time before the students graduate, and hopefully by then, COVID will already be gone. Reconsider electives. There might be some electives that need not to be offered anymore, not only because of the cost, but because of the difficulty in offering flexible learning among the different schools. Revisiting course requirements, obviously, not have the same requirements when we were having face-to-face learning activities. There has to be some modifications, and some of these learning requirements or learning activities will have to be integrated to just come up with one project or program. Okay? Examinations will also have to be modified. Paper and pencil tests may not be appropriate anymore. So we need to explore possible digital apps for exams or simply modifying exams and converting it to projects and program-based requirements. Delivery mode, of course, will depend on the access of students to resources and the need to conceptualize internship. I think this is one of the major challenges that we're having now in the different nursing schools, especially where face-to-face exposure in the hospitals are still not allowed. And therefore, adjustments and alternative activities will have to be done to make are still achieved using actions like simulations. This is also one way of describing the new normal in the implementation of flexible learning. In the past, both the teacher and the students are full-time in their roles. But with the new normal, since most of the activities very limited of the time done through face-to-face learning, then it can be lesser than the usual allotment. In our school, for example, with online modality of learning, for theory subjects and even for clinical subjects, we call it related learning activity subjects, that are implemented online, the teacher and the students do not have to be engaged for 8 hours a day as we used to do. Our school implemented a policy that says that faculty and students can be engaged in synchronous sessions up to 35%. Oh no, that's the at least 35% of the time. So instead of an 8-hour schedule for a clinical subject that is delivered online, teachers may be allowed to have real-time engagement with the students for at least 35%. Of course, sometimes we spend more, but we don't have to spend 100% of the 8 hours. And therefore, the challenge is, how can we maximize the time where the faculty and students are engaged online? And what are the activities that the students can do and the teachers can do asynchronously offline? In the past, we used to have physical classrooms, or we bring our students to the hospitals and the other healthcare facilities. At the moment, most of the time, we are engaged in online learning. In the Philippines, schools, nursing schools cannot bring their students in the hospitals or engage in face-to-face learning activities in the skills laboratory unless they are given authority by CHED, and only after complying with strict health and safety protocols and retrofitting of their school facilities. And again, that limits opportunities to students and the challenge for schools to find alternative ways by which students can achieve clinical competencies. In the past, assessments are usually done to paper and pencils. Now, are engaged in online submission of requirements. Okay, in the past, credit is basically based on the hours, the completion of the required hours, whereas progress at the moment is based on the attainment of the competency, not necessarily through credit hours already. Now, another shift and emphasis that teachers should focus on is to understand the 21st century skills of the learners. Okay, the need for the learners to be self-directed, to be globally aware, to be effective communicators, to be critical problem solvers, to be civically engaged, okay, to be critical thinkers, collaborators, information and media literate, and that is where techno-intelligence skills would come in. Financially and economically literate, they have to be innovators as well. So the question is, how can the teachers assist the learners develop these competencies, which the pandemic may not necessarily be a factor not to achieve all these competencies. So literatures would say that teachers should teach through the discipline. Gone are the days where we simply talk about the topic. Now, we have to give explanations. We have to let the learners appreciate how these particular concepts would be relevant to them as future nurses or to their roles as healthcare providers. And that can be very challenging, but this is how students appreciate learning, and this is how students get motivated to learn. Develop thinking skills. We always have to highlight on higher order thinking skills, such as critical thinking, evaluation, analysis, application, not only memory, not only understanding. It has to exceed to higher levels of competency. We also encourage learning transfer, and this is where relevant activities has to be planned so that we can really assess whether the students have understood, have learned our lessons by transferring or creating something new out of what they learn. Addressing miscommunications, okay, which means that we have to encourage students to express their ideas, to even question our thoughts as needed, because those are evidences that our students are thinking, and therefore allow exchanges of ideas, and the role of the teacher as a facilitator will have to come in. Treat teamwork like an outcome. Students often learn best if they're working with teams, where they share each other's idea, where they correct each other's thoughts. And this is a management skill that we would like to develop among them. Exploit technology to support learning. To do this, faculty themselves have to be experts in the use of technology. Well, of course, this is a continuing learning process, but what's important is we're able to guide our students to maximize the use of technology. Foster creativity. Oftentimes, what we taught may not be what will be retained on the minds of the students, but guiding them on how to create new things, how to develop new ideas, will be one of the main investments that we can provide to our students, and teach students how to learn. Teach them to be critical. Encourage them to understand their thinking process so that they become responsible for their own learning. With flexible learning, as we said, higher education institutions have choices. Oftentimes, they can simply engage in pure online activities on certain opportunities provided and as regulated. They can bring their students to the hospitals and to the skills laboratories for skills development. Oftentimes, you can also combine both. And when we say flexibility, whatever you plan can also be adjusted as appropriate. For example, at St. Louis University at the moment, we are supposed to be bringing our students in the hospitals for their clinical practice and in the skills laboratories for the face-to-face development of nursing skills. But in the past week, the COVID cases significantly surged in Baguio City among other regions. And we were under alert level 4, which means that the cases are soaring high and that the hospital facilities cannot adequately accommodate the high number of new cases and existing cases for COVID. And so we had some discussions with the hospitals where we bring our students for hospital affiliation, and we unanimously agreed that we will have to suspend the clinical exposure of the students for at least the next 2 weeks until such time that the COVID cases will be more controlled, until such time that we can ensure that our students are protected. Well, we have to understand that in the new normal, we don't only intend to ensure that learning will happen. We also have to assure that our students are safe. Actually, in one of the studies, the greatest fear of the students as they go to schools at this time of pandemic is getting infected. And that is one of the responsibilities of the school as well. So in cases like this, what do? We revert back to online learning. We have standby online simulation activities that we employed, which at the same time can develop the clinical skills of the students. Schools also develop their learning continuity plans. The need to retrofit hospital facilities and laboratories to make sure health and safety protocols are in place, together with health and safety guidelines that everybody will have to comply with. We also have to develop cyclical schedule by cohorts, which means that students will have to schedule for face-to-face activities and another week or 2 of online activities. Is to ensure that students and faculty are not unnecessarily exposed to COVID, and at the same time, we are sure that in case they are infected, these are already identified through regular testing of faculty and students for COVID. We also have available alternative learning activities that we can fall back to in case face-to-face learning activities are not allowed and is not safe at the moment. All services that higher education institutions provide to students are now converted online. Psychological counseling are done online, enrollments are done online, even medical consultations are done online. And again, this is one of the adjustments that schools had to make. Early warning systems. Schools had to identify some alarms to indicate when classes through face-to-face learning activities will have to be suspended for a while. If there are clustering of cases among faculty and students or even staff in the schools, then this is one example of an alarm where they have to suspend face-to-face learning activities, or where the administration will have to decide on some other safety protocols to ensure that everybody is protected. And with COVID pandemic, sorry for the wrong spelling, quality assurance should still be in place. And this is the role of the faculty, the department heads, and school administrators. Now, these are examples of retrofitting that are done in the schools. We had to convert some of the classrooms as skills laboratories. We had to put plastic shields between the faculty who's doing the demonstration and the students who are seated. The maximum capacity of classroom, which used to be 40 to 50 students, only 11 can now be accommodated to ensure that physical distancing. Alcohol dispensers, food drugs are in place. Safety reminders are all down. Okay, foot directions are also provided for. And students have to be very conscious of health and safety guidelines as they continue to learn. Now, what are the best practices for teaching online? Let's start with teach for online students. Students has to be oriented on how to manipulate, to explore the learning management systems decided for by schools. Okay, so that they can maximally use the different learning resources and be able to properly submit learning requirements as needed. There has to be real-world applications, as mentioned a while ago. There has to be instructor presence. Even with asynchronous online activities, teachers has to be engaged with the students, okay? Especially for formative learning assessments for individual students and feedback of their performance. Clear expectations are needed. Learning course syllabi, which used to be printed, are now converted to learning packets and modules, which are more interactive, that combines print and online references as well. Learning outcomes has to be very specific and clear. Assessment tools as well will have to be authentic and appropriate to measure the learning outcomes. There has to be prompt feedback, which I think is critical to student learning, and they have to engage students. Sometimes, as identified yesterday in the plenary, there are some students who don't react at all, even when the faculty is talking and explaining in synchronous sessions. So how do we engage students? Our speaker yesterday also discussed other alternative ways of motivating our students to be engaged. And I know that many of the teachers have their own techniques as well. Now take note that with flexible learning, there is no one hard, fast rule of how things should be done. Everything is made flexible depending on the needs of the students, the performance of the students, and the availability of resources. And engaging learners to be active in the teaching learning process is very critical. Now, this infographic by Columbia University said that students retain about 70% of what they hear in the first 10 minutes of the class. And if the class is 3 hours or 4 hours, they only just retain 20% during the last 10 minutes of the class. Okay, so we have to consider this, and therefore, online engagement doesn't have to be long. And I think that's The Merit Y in our university, a minimum of 35% of the total class time may be spent through synchronous session, while the remaining percent can be done asynchronously with clear and specific learning activities that the students will have to do and that the faculty is on standby for assistance. An instructor generally says 100 to 200 words a minute, and a student only hears 50 to 100 or half of it. And so we remind our teachers not to be talking too fast, not to be discussing and lecturing for the next 2 hours, because literatures would say that they don't understand everything the teacher would say. So we only teach the must-know topics. We engage the learners by activities where they are involved. Says here, whereas yet in a typical lecture class, students are attentive just 40% of the time. And it highlights the value of visual aids. We feel sometimes that visual aids are not very important, but many of our students are visual learners. And this generation would appreciate not just several lines of words on the screen, but fewer words yet very relevant and pictures that gives emphasis. Experiential learning can still be done even with blended learning, okay, as specified in the screen, where active experimentation can be done, concrete experience of the learners, or reflective observations of the experiences of others, as well as abstract conceptualization through cases that the teacher may be providing. Now, other learning examples are provided for here. Case-based learning, project-based learning, inquiry-based learning is very important, where the students will have to explore other relevant information that they can access online or through print. Even allowing the students to come up with mnemonics is one way of making the learners active in the learning process. Volunteering is also highlighted there. Now, in the Philippines, we are currently crafting a guideline, a regulatory guideline that students who would be volunteering, medical, nursing students who would be volunteering in the different vaccination campaigns of the government may credit their involvement as volunteers as part of the clinical hours. And this is something interesting. But of course, this is on a volunteer basis only. We cannot compel our students to volunteer in vaccination programs, especially if there are risks involved. Now, other innovative learning activities that can be done to increase the clinical competencies of students, aside from modular learning, of course, is employing different types of simulations. There are virtual simulations which can be subscribed by the school, but this can be very expensive. And oftentimes, some of these subscribed simulation cases do not actually fit to the learning outcome set for particular nursing subjects. So we encourage our faculty to develop their own virtual simulation cases that are actually more appropriate to achieve the learning outcomes that we want. And this is where we see the innovativeness and creativity of faculty. We also use standardized patients, which can also be done online by faculty or some relatives or some interested individuals may serve as patients to simulate the actual clinical scenario. We also use low fidelity up to high fidelity mannequins that would simulate a patient, okay, if it is not safe for the students to go to the hospital yet to learn. We also have academic partner practice initiatives which are being done by some schools. For some schools who cannot bring their students to the hospital to learn, they partner with some hospitals, the nursing service of some hospitals, where they video certain learning activities, or where the students can interact with the staff nurses as they perform certain clinical work in the hospital. Do all these activities achieve learning outcomes? Some of them may be, but it's better to have alternative learning activities but not providing any learning activity at all. So the next steps while we implement innovative teaching learning activities is to conduct studies and researches to evaluate whether it's really achieving learning outcomes, and we encourage our students to do these kinds of researches. We also do regular quality customer satisfaction survey at the end of every semester to know what are the strengths of the implementation of flexible learning and to know areas that we need to further improve. So what are the opportunities available in the new normal? The opportunity to innovate, the opportunity to be creative, where even regulatory policies of the Commission on Higher Education can be laxed, can be, less stringent than it used to be. So creativity is very important. Benchmarking from the best practices of other schools, locally and globally, is also a way to learn, like having conferences like this. It's affordable, it's free, yet we continue to learn. Wider opportunity for networking with schools in other countries, which used to be restricted if schools do not have funds for this. And borderless learning is also an advantage. What about for the students? Students, how can they be successful in the new normal? One, they have to be self-directed learners. They have to be responsible for their own learning. It says here that's a process with or without the help of others or the faculty to diagnose their learning needs. What did I understand very well? What skills have I mastered and what skills do I need to further develop? Okay, what will I do about it? Okay, you implement your goals and evaluate at the end. So, a learner, for example, would have to ask himself, what am I being asked to do? Do I know this already? What do I need to know? How do I plan to learn about this? Okay, what are the steps to do? What progress am I making? Meaning you also evaluate your performance as you implement your plan and come up with your own reflection. What would I change or do differently next time? That is being a good self-directed learner. And what are the benefits? Okay. Praxis would say it teaches you to take initiative and create value. It builds self-confidence. It teaches perseverance and flexibility. It kindles intrinsic motivation, promotes self-awareness because of the reflection that you have to regularly do. It helps you find a career that is fulfilling to you personally, because part of being self-directed is creating your own learner's portfolio which will serve as the repository of all evidences of learning, all evidences of competencies you learn, and your own reflections of your own learning. Okay, teaches social skills, explore wider range of interests, and give you practical experiences. So, my dear students, among the participants, be self-directed learners. Effectively manage your time as well. Several literatures would say that time management is one of the critical coping strategies in the new normal. Come up with your to-do list and make sure that you set your priorities in consideration of the complexity of the learning requirements you have to do, the time that you need to spend for synchronization, some activities that may be delegated to others, except of course the learning part. Celebrate success, okay? Because it means that all your efforts are coming to fruition. Time management, rest. Part of time management is allotting time to rest. Adequate sleep is also very important. Time to learn so that you can maximize the use of technology and so that projects and all learning requirements are done on time. How to do this is something that you will have to discover yourself. Strategies that may be done by one student may not be effective to another student. So explore and find the best ways of dealing with time in consideration of the learning activities and learning requirements to get credit for your courses. Be active learners as well. How do you do this? Feel it. Try to be curious. Do advanced reading yourself. Relate it. Relate it to more concrete learning experiences, both personal and professional experiences as future nurses. Solve it. Questions that may be raised would be an opportunity for you to find answers yourself. You don't have to wait for your teacher to provide all the information to you. Reflect in writing. Sometimes when you write, it further retains the knowledge. Okay? So we used to have requirements that we want our students to be written, handwritten, not encoded, because we want them also to process their own thinking as they perform the learning activities. Okay? Control your environment. That's very critical. Minimize distraction, focus. Come up with your own summary of what you learned for the course, for the day. Sketch out the concepts that relates to your life. Sometimes when you articulate your understanding to some creative works, it somehow retains learning as well. Comparing notes with others, self-assess. Sometimes you learn best if you discuss with someone else, especially classmates in the same courses. Try to employ both convergent thinking and divergent way of thinking. In the divergent way of thinking, you try now to learn different concepts and use all these different concepts in solving a problem or a case that is presented to you. Divergent learning, on the other hand, okay, is start with a problem and look for several solutions from different sources. Humor is also very important. Oftentimes, students and even faculty would be depressed or would be stressed with a lot of responsibilities. And so find time to laugh, to watch your favorite movies, to read your favorite book, for example, to do artwork or do other activities that are very interesting to you, because that somehow reduces stress and prepares you and rejuvenates you for the next learning activity. Be resilient as well. Literatures would say that resilience can be physical, which means that you have to take care of your own health well. Mental, you have to identify certain focus, okay? Think of the point of views and identify what is important for you to learn. Emotionally, you need to handle your stress. You have to identify your own coping strategies. And oftentimes, spiritually, this may help for some learners. But more than this, students also have to be digitally resilient. Digital resilience, as identified in this slide, is having the awareness, skills, agility, and confidence to be empowered users of new technology and adapt to changing digital skill demands. Digital resilience improves capacity to problem solve and upskill, navigate digital transformation, and be active participants in society and economy. Oftentimes, students will consider technology as their friend. Sometimes they're even more advanced than some of their teachers, which is very interesting. And this should be a challenge to the teachers as well. You will be surprised with how much resources, relevant resources are available online. But to be digitally resilient, you also have to be selective of what is correct, what is scientific, what is evidence-based, and what is grounded. Sometimes with information explosion digitally, you will be overwhelmed, and sometimes you will be misguided if you don't know how to select the right information for you. So, in the new normal, be digitally resilient. So these are the references for the slides. Thank you so much for the opportunity. Okay,
Thank
so
you
I
so
now give
much.
the floor to our MC.
Thank you so much, Professor Grace, for the informative information about teaching and learning in the new normal. And for the digital world, both teacher and student have to adapt ourselves. And the advantage might be for teachers, no matter how old you are, but you have to learn and have the more skill of digital skill. And as me at the beginning might be difficult, but now we have to adapt ourselves. And for the student side, they might have more active learner and self-directed learner as well. We still have some time for the question from the participant. Any participant have question? Oh, one student have question.
Thank you. I have question. My name is Krishanan Songsang, nursing student first year in Brom Rachonani Payao Nursing College. As you are a nursing teacher, do you think that teaching in new normal is effective enough to teach nursing students? For me, sometimes I am afraid don't pass the nursing license exam when I graduate become. It is very hard for me to study online in nursing.
Okay, thank you. That's a very interesting question. I think that fear or that question is in the mind of all students, especially the graduating students or those who just graduated last school year. Because of the several adjustments in flexible learning, the schools have not really implemented the curriculum the way we used to do, which has already been proven and tested to be effective. With innovations and alternative ways of learning, we of course have to consider the limitations, but at the same time, with innovation on how to deliver instruction and making sure that the learning outcomes are achieved by the students or the skills are achieved by the students, then we are confident that our graduates will be prepared for the licensure examinations. And this is why the value of quality assurance mechanisms has to be in place in each of the higher education institutions. There has to be quality standards that will have to be set despite some level of flexibility. There has to be assessments like customer satisfaction surveys among the students and faculty employed or being engaged in flexible learning. There has to be additional reinforcement activities based on our continuing assessment, whether our students have developed the competencies or not. And well, it increases the challenge posed on teachers and schools, but I think we can do it this way. There is no other way because we cannot insist on going back to what we used to do. After all, we're already in the new normal. Now, the new term coined at the moment is a better new normal. That is when we can effectively cope up with the new normal. And that is the challenge not only to the teachers in the school, but also to the students as we are in this very critical period. I hope I answered the question.
Cool. Thank you very much for your answer, and I so appreciate that St. Louis. I saw from the screen that all nursing students who graduated last year always pass 100% for the nursing license, right? And so I appreciate very much, and I know that you as the teacher gave a lot of effort to do that. And we might have one more question, last question for this session. Any question you have, feel free to thanks. Okay. No more. No more. Okay, I pass the microphone to the moderator.
Thank you, Professor Dr. Mary Grace Racanaria, for your fruitful presentation. We have learned a lot about nursing system we have learned a lot about nursing study systems during COVID-19 that quite different a bit from our university. We hope that learning methods you have used on I hope that learning method can use on the other side of the world, including Thailand.
In next session, we will have a third keynote speaker, Dr. Rossi Stanhouse from School of Health and Social Science, University of Edinburgh, Scotland, United Kingdom, to talk about potential roles of education and clinical professional in disruptive world. Let me tell you more about Dr. Rossi Stanhouse. Dr. Rossi Stanhouse is a senior lecturer in nursing studies and associate director of the Center of Creative Relational Inquiry. Her work is strongly driven by a commitment to social justice with a methodological focus on voice and the power relation within research production. This had led to the use of narrative and creative methodologies which deeply explore the health-related experience of marginalized groups and creative representation of this experience as a means to decenter the authoritative voice of the researcher. Projects include digital story making with people with dementia, narrative of newly qualified nurse, narrative research into mental health patient experience, and the development of poems to represent participant story. Everyone, please welcome Dr. Rossi Stanhouse.
Good morning, Rosie.
Good morning, Tony. Lovely to see everybody, and thank you for that lovely introduction. Okay, will I just get on and share my screen? Oh, wait a minute. Oh, come here. This is what I'm looking for. Oh, sorry, it's not quite behaving itself. Hold on a minute.
Yes, I can. Yeah. Perfect.
Wait a minute. Let's just try. Let's try again. Right, slideshow.
Yeah.
Okay, can everybody see that now?
Yes, I can see your PowerPoint.
Lovely. Okay, thank you very much. So thank you very much for inviting me to talk to you all today. It's a real honor to be part of this conference again. I had the pleasure of coming to Thailand for a couple of years to be part of this conference as well. So it's really lovely to be here and to be talking about the potential roles of education and the clinical professional in a disrupted world. So I thought I would start by showing you a picture of Edinburgh so you get a sense of where I am. And so this is a sort of view over the top of Edinburgh towards the hills, and these are the buildings that that actually my office is situated in an old medical school quad. So just to give you a sense of where we are. And I thought I would start today by talking about disruption, thinking about a disrupted world. So we'll start there and then thinking about what form does that disruption take that is caused by COVID-19? And then what have been some of the responses to the disruption caused by COVID-19? And here I'm thinking about mostly the responses of health services. And then thinking from that, what might this mean for nursing practice and nursing professionals moving forward, and the education that we provide? So some of what I say, I can, having just listened to Mary Grace's presentation, I can see connections between some of the things that I will say and some of the things that she's been talking about just now. So to start, thinking about disruption then, and when we think about disruption, often we think about it has negative kind of emotional connections, and that particularly is related to this first definition of disruption here, the action of preventing something, especially a system, process or event, from continuing as usual or as expected. And it's this part of disruption, it's about it stopping everything that we know, that we take for granted as happening as part of our everyday lives, that is so challenging to us, that it stops all of this everyday experience and sort of throws it up in the air. But the second definition of disruption that I have here is, or the second aspect of the definition of disruption is feels a little bit more positive. It feels like it's about the opportunities. So the other definition is about the action of completely changing the traditional way that an industry or market operates by using new methods or technology. And this, I think, if we think about disruptive technologies that we will have come across, so you will probably all have smartphones, and smartphones were a disruptive technology. They suddenly meant that we didn't have to be at a computer to get to connect to the internet. We could connect to the internet wherever we were through a mobile device. So that kind of use of technology to find new ways to work. And I think that's very much what has happened during the pandemic, that many of the technologies that already existed, they maybe being used by much more people, or the engagement with them has been different. They've provided us with solutions. So we'll keep these ideas about disruption in our head as we go through this talk. But what has that disruption looked like? Health services, and I wanted to think about global health services, not just UK. And the World Health Organization has been doing regular surveys of global health services to find out what they have been able to keep going and what has been disrupted and what the causes of that disruption are. And so the causes of disruption from this latest survey, which was published in April 2021, so it was for the beginning of 2021, was the redeployment of staff. So taking staff from other services, perhaps outpatient services or community-based services that were not COVID-related services, and bringing them in to work in COVID-related services to give enough staff for those services. So redeployment of staff has caused disruption, and that's led to the closure of some non-COVID health facilities. So some of the services that we would usually have closed. People don't have access to them at the moment. And then supply chain issues, leading to a lack of medicines or diagnostics such as tests and personal protective equipment. Certainly, we're very aware of these issues during the first wave of COVID-19 when we didn't have enough, for instance, for the nurses and the doctors working in the hospitals. And this is an issue that also leads to inequalities, because as a high-income country, we were able to get supplies from other countries, but that meant that some of the poorer, low and middle-income countries who had less support, their nurses and doctors were left without the personal equipment. Those are the causes of disruption. And I thought it is also useful to understand the areas of service that are disrupted. And one of the key issues that has been identified is that patients are not seeking care for non-COVID related healthcare issues because of fear of becoming infected. And within the UK, for instance, there have been significantly less diagnoses of cancers this year in comparison to pre-pandemic years. And the understanding is that's not because people are not getting cancer, but because people are not going to the hospitals, they're not going to the doctors to get diagnosis. The everyday primary care services are what has mostly been affected. In over half of countries that were surveyed, that's what's mostly been affected. And that also impacts people, a lot of people with long-term care for chronic illnesses, who maybe are requiring rehabilitation services or palliative care services. And so this also impacts particular groups of the population. So older people and those with disability have perhaps been disproportionately impacted by this. 20% of countries said that life-saving surgery had been disrupted, and 2/3 of countries had disrupted their elective surgery. And that certainly has been a common response to be able to free up the capacity of a health service to take in people with COVID-19 who maybe require intensive care, but also to free up personnel, so nurses and doctors and other healthcare personnel. And then in more than 40% of countries, there have been disruption in mental health and drug misuse services, in services for people relating to bloodborne viruses, so HIV, hepatitis B and hepatitis C, non-communicable diseases, urgent dental care, contraception and family planning, tuberculosis, cancer screening and tropical diseases, all key areas of healthcare that provide vital care, which have been disrupted. So people requiring these services have been less able to access these. And so this is the extent of this disruption. And then let's think about, okay, so what are the health service responses? How have health services kind of taken these problems and innovated and responded to these? And many of the health service responses have been driven by the public health requirements in relation to social distancing, in relation to preventing people from congregating in public places, perhaps trying to reduce the amount of people using public transport, for instance, but also in response to lockdowns, so national lockdowns or lockdowns in relation to public transport. So in the UK, we've had 2 fairly long national lockdowns where people were really to stay in their houses. They were allowed out for maybe 1 hour or 2 hours a day. They were not allowed to travel further than 5 kilometres from where they lived. So that kind of public health move to try and contain the spread of the virus then required health services to respond in quite different ways. We couldn't just keep providing health services in the usual way. So one of the things that has really happened has been a focus on providing care and support to people in the community to prevent people from travelling to the hospitals in the cities, for instance, from getting on public transport, trying to keep people in their communities and care for them there. And actually, I was looking at the World Health Organization work around about this, and I came across some really nice a nice video about actually what you've been doing in Thailand, and I hadn't realized you have a volunteer community health workforce who had been trained and prepared to work in the case of a pandemic and have done a really vital work to support people in the community to get the public health messaging across, to provide some basic health care and resources, and just enable people to feel okay and supported and looked after. So engagement with communities has become really vital, and that has also led to the use of digital technologies. So across many countries, I'm not sure whether you have this in Thailand, but across many countries we've had an app, for instance, for monitoring and tracking the virus and enabling contact tracing, so that then people can be told they've been in contact with the virus and they can isolate. So digital technologies have come rapidly into use for that kind of work, but also to help healthcare workers engage with people in the communities. So this rapid adoption, the rapid use of digital solutions, innovating in a way to take technology that existed and use it to enable video consultations between patients in the community and consultants or medics or nurses in the hospitals or in the clinics or the health centres, so that people didn't need to leave their homes. And that has been a really big growth, certainly in the UK and in Scotland. And in Scotland, it was already part of our Scottish policy. So we have a lot of, a number of remote areas. We have a number of islands where we had then been trying to encourage populations to engage with technology to get access to healthcare. And what has been found is that the disruption caused by the pandemic has increased engagement with video consultations and other digital health solutions, and that then means that the objectives that were set in Scottish policy to engage communities with digital health have been accelerated. So this is an example, I guess, of the opportunity created by the disruption to accelerate progress in some directions that we were already travelling in, but rather slowly. There's also been rapid training of non-critical care staff, non-ICU staff to work in critical care settings. And that's been something, so that is linked to the redeployment of staff that I was talking about. And it's been quite a key feature in many health systems. And it has then changed the role of nurses who are critical care nurses, who are then also teaching and supervising these new staff who have come in to help in critical care when it is really needing resources. But there are also implications for these staff coming into critical care who are not critical care nurses, who are coming in when it is really busy, where there's a lot of stress, a lot of pressure, and there has been an impact that is coming through in the evidence around the impact on their mental health. And finally, thinking about health service responses, these have been data-driven responses. So there is a kind of perhaps a renewed focus on data to understand in relation to COVID, to understand where the impacts are and then be able to design interventions and health service responses to deal with those. And I wanted to give, so that's quite, I suppose, general sense overview of the impact on health services and the responses of health services. And I wanted to give an example of a specific nurse-led innovation, which actually has been developed by some of my colleagues in nursing studies at Edinburgh, who are critical care nurses. Their research work and their scholarship and their practice is focused on critical care. And they had done previous research exploring the needs of patients and families and nurses in critical care, thinking about what do patients and families need to feel really supported in this difficult time and in this environment. And they then used this knowledge at a period where we have had a long time where relatives were not allowed into hospitals. So people were coming into hospital in the UK. They were critically ill. Some of them, many of them, were dying, and their relatives were not allowed to be in the hospital with them. And that was really difficult, as you would imagine, for the families of these people, for the patients, and actually also for the nurses. So these colleagues took this understanding that they already had, and they found a technology called We Create, which is a video messaging service which our National Health Service approves of, that it's secure enough. And they then developed a project where they would go in and they would use the We Create knowledge to be with patients, for instance, and help them send a message to their families, but also families could send a message into patients, and the nurses could message the families as well. So this was a way of helping relatives and families stay in touch with people in the intensive care unit. And that really, I guess, also then really demonstrates a new role for nurses in using this technology to keep in touch with the relatives of these patients. And I've talked a little bit, I've referred to the impact of working in the pandemic on healthcare workers. And we do have evidence from the SARS pandemic and from the Ebola pandemic that actually working during a pandemic has an impact on healthcare workers' mental health. And Lai and colleagues have produced evidence from COVID-19 quite early on, and there will be more evidence, now is published to demonstrate as well that actually there are high levels of depression and anxiety, insomnia, post-traumatic stress disorder symptoms found in healthcare workers who have worked during the pandemic. And these have consequences for the individual health workers, but they also have consequences for health workers staying in the healthcare system, and they can lead to people leaving the system. And so it's really important that hospitals and organisations put in support for their workers. The support can be organisational, so it can be changes to how people work. So huddles, which are kind of stand-up meetings where people sort of quickly exchange information so that everybody knows what's happening. Brief communications, space. In our local hospitals, they allocated some space to healthcare workers to have quiet time to help them just get some rest when they were on shift. But they also did things that were quite small things, you would think, but made staff feel valued. So they made parking free. So normally staff have to pay money to park their cars there. So they give free parking, and they don't normally have access to hot food on night shifts. So they gave access to hot food on night shifts, and that made staff feel more valued and more supported. And then they also provide individual support as well to staff. So there were some sessions in terms of things like yoga, reflexology, aromatherapy, but also counselling and telephone helplines to help with mental health problems. And I've already talked a bit about the challenges for the profession in terms of it's possible that we might lose nurses from the profession. One of the things that has really perhaps been a huge benefit to the nursing profession is the increased visibility of nurses now. So the pandemic has increased nurses' visibility to the public and to governments in terms of the vital role that nurses play in healthcare. And in the UK, we've seen 30% more applications to nursing programmes of people wanting to become nurses this year in comparison to previous years. And the ICN have identified that actually across many high-income countries, particularly, although also in some low and middle-income countries, there have been increased applications to nursing programmes. So that has increased people's motivations to become nurses. As I say, there is an increased risk of attrition, and healthcare nurses need political support. So here in the UK, and I'm not sure what's happened in other countries, there was a lot of support by the government saying how much they valued nurses during the first wave of the pandemic. But there was no support for a pay rise, for instance, which then makes nurses feel not valued. And across many countries as well, there are issues with the working conditions that nurses and other healthcare professionals are working under. And if we think about particularly things like access to PPE and how many nurses particularly in low and middle income countries are working in areas where they don't have access to sufficient quality or sufficient amounts of PPE. And nurses also need supported by their organisations, as I've just said as well. So then what does all this mean for the possible change in roles, or maybe not change, but certainly how does this impact the role of the clinical professional? And as I talked about at the beginning, this disruption, it disrupts this sort of sense of normal flow of things. And many of the things that I'm going to talk about as what I think are probably the implications for professionals are things which were things that we were thinking about, but there was perhaps resistance from different groups to the implementation, for instance, of a lot of digital technology in healthcare. So it was slowly coming in. But what the pandemic has done is created a situation where we've had to make significant changes in how we work. And it's not just going to go back to how it was before. We've heard this phrase, the new normal, quite a lot. And it really is. We cannot go back from that. There will be things from before which we can start doing a bit more, for instance, in terms of sort of face-to-face consultation, but there will be things that we keep. So I think the professionals, we're going to become, I think, probably more engaged with innovating in relation to our use of digital technology, both in terms of how we use the technologies that are available to us, and also the extent that we engage with technology in the care we provide. And that we are also then, as technology becomes much more part of our care, we need to learn how to support patients and families to use that technology. And to be working collaboratively with other health professionals to develop innovative solutions. So working as teams, again, in that previous presentation, there was talking about teams and working together, and this is really key to developing innovative solutions. I do worry that there's a potential widening of the gap between high income and low and middle income countries in terms of what is possible, where we are really taking a move towards the use of digital technology much more in our healthcare and our nursing care. And that's not necessarily because of a lack of the digital hardware in low and middle income countries, but in many of these countries, the infrastructure for broadband, for internet connectivity is much more fragile, and it makes it much less possible to use these innovations so much. And as we do all of this, we will need to be much more engaged as nurses with being data driven. So the next area, I think that we already lead care. Nurses are leaders in across the globe in many areas of care. I think we will continue to do that, perhaps more visibly doing that. And perhaps there are new opportunities because of our increased visibility for nurses to be involved in shaping policy and in some of these higher level discussions. I think that there is an interesting sort of double focus now of healthcare. So a definite focus has been made much more visible of public health and the need to focus on community and understanding the complex relationship between patients, families, communities, and the social and physical environment, and how that impacts their health and how public health can work in this field to improve people's health status and to protect people, the health of people. And then I think there's the other side, which is critical care, which we have seen there was not enough of a critical care trained population to enable us to deal with the effects of the pandemic. So the shift towards community, I think, is in tension with this this need to have these practitioners who are really well trained in relation to critical care. Again, nurses have always been engaged with research, but this change in the context that we're in has opened up opportunities for, and the need for innovation has opened up opportunities, and the need really to develop an evidence base that looks at evaluating many of the interventions and innovations that we've implemented on the basis of our previous evidence, but that we don't really know how they work in this new context that we're using them in. So there's a need for clinical professionals. So this needs to be part of our everyday work, not just done by academics. So there's a need to be evaluating what we're doing, working out what works and for whom in what context, and really engaging with the data and the data science, these big data as well that are available that enable us to understand what we might implement and how we might innovate. And then the final area that I think is important for us to really think about as clinical professionals is our political engagement. So nurses are the largest healthcare workforce, and yet often have not a very loud voice in the policy making at the policy making level, and in relation to some of our other health professional colleagues. So we need to develop that voice. We need to become politically engaged. We need to be able to engage with policymakers to improve policies that affect both staff and working conditions, but also that affect the patients that we're looking after and the outcomes, the health outcomes that they have. So we need to strongly advocate for improved working conditions for nurses. And we also need to strongly advocate for support for nurses' well-being, particularly in the context of this pandemic, but not only in the context of the pandemic. So it needs to be ongoing through increased resources and organisational support. So if this is what we're looking at for clinical practitioners, then what do we need to think about in terms of nurse education? And in nurse education, we are always educating for the future workforce. Except in the past, up till last year, we could always feel comfortable that we could predict what the needs of the future workforce and the health of the population would be, because things moved slowly. We had that normality that was quite predictable, that change didn't happen as rapidly as it has happened now. And so the disruption has made it much more challenging to think, what do we need? What do nurses of the future need to be able to do to care for our patients and our communities, and to work in a way that also cares for them as well. And so I think we can see that we need a flexible and an innovative workforce who are able to collaborate, communicate, who are creative, and who are critical thinkers. And much of how we create those key features of our nursing workforce is about how we teach, so as well as what we teach. And so in the previous presentation, Mary Grace talked about teamwork as an outcome, so about valuing teamwork as a process that we see as being an outcome that is valuable in itself. And we can teach in ways that enable students to develop their teamwork abilities through the exercises we give them to do together, through the assessments we ask you to do. Digital literacy skills, we have seen through all of these presentations, the digital is there, technology is there. It has been a key part of our response to COVID-19, both in education and in healthcare, and it is going to be vital moving forward. So again, students will be requiring to develop their digital literacy skills and then have good enough skills both to be able to use them to innovate and to work, but equally to educate and support patients and families to use the digital as well. And as I've already talked about, data science skills will be important as well. But as well as these sort of, I suppose, hard science type skills, I think there are the arts side of nursing needs to be attended to. We need to develop people who are compassionate, able to relate to the people that we work with in our communities, but who are also able to look after ourselves and understand and reflect on the impact of doing our work on ourselves and be self-compassionate and be self-caring. So for me, that means that we also need to make sure that we engage students with the arts, humanities and social sciences as well as the life sciences. And this is also where the creativity comes into. But things about thinking about the role of the arts, for instance, in relation to patient or staff or student well-being. And also thinking about the role of social science, enabling students to understand the connection between social circumstances, health inequalities, and health outcomes, so that then that much wider understanding and connectivity with communities really underpins nursing of the future. We need to teach our students and encourage our students to become politically engaged, and some of that comes through being critical thinkers, but also about teaching about how to engage. What are the ways that we can engage? What kind of skills do we need? And finally, much of what I've been talking about in terms of education has been thinking in terms of undergraduate education. But we need to also make sure that postgraduate education and continuing professional development are accessible. And these have proved really vital during COVID-19, and they need to be freely accessible. The use of digital technology has made them much more widely accessible. You can do things online now, but they need to be free as well. Okay, so thank you very much for that. I hope that's been useful to listen to, and I'd be happy to take any questions that you might have.
Okay, thank you, Dr. Rossi. My name is Chuliporn Pusopa. I am a lecturer of Motivational Nursing College. Thank you for your sharing the valuable nursing knowledge for us. We learned a lot from you today. I didn't believe that you can use smartphone for support mental health of patients with COVID-19. That's more than 90% of Thailand people, we use smartphone, but we didn't recall that we can use smartphone for supportive mental health of our patient. Before you finish your presentation, how about the floor? Who have any question for Professor Dr. Rossi? For the online question too.
Hi, Lucy.
Hi, Tony.
Yes, thank you very much for your presentation. It's very nice. And thank you for your time that you give me your beautiful presentation to my nursing student and nursing student around the world. I think your talk is very useful and to encourage our nursing staff in the academic institute to think about how to use digital to change the teaching methods for nursing students in the COVID-19 or in the new normal, right? It's very useful. And I would like to encourage our nursing staff to think about this, because in the new normal era, we have to think about how to move on for the nursing education in the future, and how to think about the shortage of nursing professionals in the hospital or in the nursing service, something like that. Because from the COVID-19 situation, the shortage of nursing professionals in hospital is rapid increasing every day, right? And nursing students, they're scared to come to the nursing professional. Yeah, I think this situation is have to reform and have to decide how to encourage nursing students come to nursing professional in the future. Yeah, thank you.
Yeah.
Yes, and I would like to read the message from the chat. Thank you for your very excellent presentation. You are right, this a challenge, but you have very excellent strategy and idea. Yeah, this from chat. And thank you, Dr. Rossi. Thank you so much. Dr. Grace too. Hello, Dr. Rossi. Good to see you. It's from Norinia, from Central University.
Lovely to see you all too.
Right.
Yeah.
Thank you.
So,
Thank you.
when you were talking about nursing students be scared to come to nursing professional, have you seen a reduction then in the numbers of people wanting to be a nurse in Thailand just now because of COVID-19?
Yes.
Yeah.
In Thailand, the number of nursing profession is quite intention to leave nursing professional is increasing every year, right? And we have the situation of shortage nurse in the hospital, particularly in the COVID-19 situation. Yeah. And nurse works very hard. Nowadays they work hard.
Yeah, and I think this is a real danger for the profession. So
Absolutely.
much as nurses have become really visible through their work during COVID-19, I think it's a real point of danger. Before the pandemic, the state of the world's nursing said that we were 6 million nurses that we needed in the world. And unless governments start to sort of put more resources in and value nurses more, I think that what will happen is we will see nurses leaving, a lot of nurses leaving, like you say, and not enough nurses starting their education.
Yes.
So we need to work hard to try and influence how that happens.
Yes, me too.
Yeah.
I have to design the strategy to encourage new nursing students come to our professional, right? Work hard. Work hard for director and work hard for nurse lecturer.
Yes. And one of the things I guess we have to be very, strongly doing, and I'm sure you're doing as everybody is in these nursing schools, once we get, when we have our students, we are really supporting them to get through this period, which is very difficult.
Okay. Any questions from the online from the online participants? We have a lot of participants from Philippines and yes, a lot. Well, a lot. Any questions from new friends from Philippines? Do you have a question? No, nothing.
Dr. Tony, I have one question for Dr. Rossi. Okay, Dr. Rossi, can you share me about your experience when your student practical clinical nursing in the hospital during the COVID-19? Because around next month, our students have to practice in the hospital. During situation, how you deal with their fear or they worry about the infection or something like that?
So that's a really good question. And during the first wave of the pandemic, the hospitals made a decision that they would take the more senior students, but that our more junior students would not have clinical placement. And before any of the students went out into the hospitals, they had to do a COVID risk assessment, which assessed whether they were individually at high risk of COVID, maybe because of pre-existing illness or some kind of health issues, or maybe to do also with their body mass index, or their age, because these were the risk factors that at that point we knew were made people more vulnerable to, and also actually ethnicity as well, and made more people more vulnerable. So they did a risk assessment. Going out into placement was also made voluntary. So students who were really anxious didn't have to go into placement. That created some issues for later on because they all have to do the hours, but we made it voluntary. The students then, if they wanted emotional support, they could contact, we all have a small group of students that we're in charge of, so they can contact us and come and speak with us about their fears, about their anxieties, to get support. There were also other support, so counselling and helplines were available to them too if they felt it was impacting their mental health. Many of our students who worked actually, particularly working in the really much more sort of critical care areas, felt they really learned a lot, felt they had had an amazing time and really grown through it. Some of our other students did struggle with it, and students then could do a longer placement or they could finish slightly earlier. So that these students who struggled then just came out of placement and stopped earlier. So a lot of how we dealt with it was about the voluntary nature of it. Over then the past 6 months, we have had students much more in placement. Again, they still do risk assessment. The clinical areas had been a bit quieter. They've got used to coping with COVID, which makes it easier for the students and for them to support the students. And now placement is not voluntary unless, obviously if you're at high risk, because when we do the risk assessment, you don't go in, but otherwise they do go into placement, and we support them with their emotional anxieties as we need to.
Thank you so much for your answer. Okay, did anyone have any question for Dr. Rossi now?
Can I ask from, we have a friends from University of Newcastle, Australia. Mieko. Hi, Mieko.
Hello.
Yes, you are new friends. Yes.
From, thank you.
Yes, from University of Newcastle. Do you have any questions for Dr. Rossi?
Okay, sure. Thank you for the lovely presentation. I learned heaps. I was fascinated with the initiative, nurse-led initiative of V Image. Mm-hmm. Is that how do you use iPad or some sort, or some, you have to dial, connect to some internet service, or can I have a bit more information about that?
Okay, so yes, so the V Create is the software, if you like, or I think it's an app actually, probably, but yes, it was on iPads. So the nurses had iPads in intensive care that they could use the V Create messaging service to do these video messages on. And the important part, for the health service was that this particular application or software was secure, because there obviously are a lot of considerations of data security. So that was why it was used. But yes, so it was on iPads, and the hospitals now generally have good Wi-Fi all the way through the wards.
Oh, that's brilliant. Thank you very much, Dr. Rossi.
Thank you. Lovely to meet you.
Lovely
Rossi,
to meet you.
Oh, thank you. Rossi, how about your idea if we use AI and robot instead of nurse in hospital?
Oh, right. So there's that's moving me on a little bit from iPads. So I think the whole AI debate is quite interesting. My sense is, and I don't know an awful lot about AI, but my sense is that there is the potential to use robotics for providing some care. But that actually people need human interaction. And I think one of the things that even with video consultations through a screen like we are doing now, that people struggle with that not being in a room, and you do lose something even through a screen. You lose that connection that you get when you're with somebody. And so I think there may well come a time when AI has a place for doing some things, so perhaps for doing some routine things, but I don't think we should lose sight of the fact that many of the things that we might call routine, I'm thinking about blood pressures and things like that, are a point where we also talk to the person, ask how they're doing, get a sense of their emotional state, their psychological state, their physical state. And I would be really sad, and I don't think it will help people if we lose those small opportunities for connection, which I think would be the points that we're in danger of losing, because people say, well, it's just a task. Well, actually, it might be a task, but it's also an interaction. And I think as nurses, this is where, again, we need to be able to have a position on this as a profession and have a voice, a strong voice, because essential to nursing really is the relationship with the patient, with the family, with other staff. And I think that it's our voice that's needed in those conversations to ensure that we need to build capacity. Yes, we need to make sure that we use technology where it's appropriate, where it can improve things. But I think we also need to make sure that we don't just go down a route of just because we can use technology doesn't mean that we should.
Thank you very much. And for Eastern culture, we have a spiritual care, right? Robot and AI cannot. Yes, we cannot use AI or robot for the spiritual care in Eastern culture, right? For Eastern country. We have a message from the chat. Hello, Dr. Rossi. What can you advise to us, nursing students who are especially from the Philippines, who are being overwhelmed because of the pandemic? And are there any other motivational words you can give us to continue pursue this profession amid this uncertainty? I cannot find because it's small letter. Especially that we are the first batch of our new curriculum and will be graduating next year.
Yeah, so thank you for that. I think my advice to nursing students is to use all of the support that's available to you. So make sure you talk to people about how you're feeling, whether that's staff in the institution or staff that you're working with in clinical areas if they have space to talk with you, or whether it's friends or family or other people. But make sure you talk about how you're feeling. It might be that you need to talk to somebody in a counselling service or who is a professional, and that is okay. Okay, it doesn't mean that you are not good enough or not coping. It's just sometimes we need to talk to somebody who is a professional and is not part of our family or our friends. And so I would say talk to the people that you have who are supports. Make sure that you're eating well, that you're sleeping, get enough rest. Make sure that you are doing things that you enjoy doing. So again, the previous presentation talked about sort of watching your favorite film, making sure you have a laugh. Also talked about actually managing your time and making sure you had time for rest. I think those are really, really important. But making sure that you do things that help you kind of relax. So it might be if you do sport or if you use arts or other things that you use to help you relax and feel grounded. So I think they're all really important if you're beginning to feel overwhelmed. And I think we all need to, and we have all had to over the past 18 months, develop these ways of looking after ourselves, which probably we hadn't had to think about before. And I think that that's really important to use those and to remember that it will not always be in this critical stage. So we're 18 months into a pandemic. We've had several waves of virus, and it kind of different countries have experienced it differently, and we're all learning at the same time, and all with different amounts of resources to manage the virus. But it will not be like this forever. We will get through the other end of this, and the important thing is to have that support and use that support to help you get through. And as the first batch of students coming out this new curriculum, I think your experience will have been different, because just like our students, you've been learning in a different way. But I think what we would say to our students is that even though you're learning in a different way, we are still making sure you're getting everything that you need to qualify. And we are here to support you. And that we then look to support you in that transition across into being a newly qualified nurse as well. So I would say that whilst this feels like it's gone on forever, when you're 50, you realise that 18 months probably isn't as long as it feels when you're only 20. And it won't stay like this forever. So it's about, in the moment, getting the support, using the support, and trusting that the new curriculum, that this new way of being taught has been different, but it has equipped you with the knowledge and the skills to go out and be a nurse. Does that help?
Yeah, it's very helpful. I think it's very helpful for us. Did anyone online or just that have any question? I think maybe we didn't have any question for you, Dr. Rossi. Thank you again for your nice presentation. Maybe I return this stage to my MC.
Thank you, Dr. Rossi, for your interesting speech. We learned a lot from your healthcare system that did not take care only patient but also keep an eye with healthcare worker. We hope that we can adopt these systems using in Thailand. Everyone, please give appreciation to our keynote speaker for today. Then from now to 8 p.m. we do have this session to do virtual presentation, research finding and innovation. The participants can enter your room by Zoom meeting ID and password from the scheduled conference.
We have finished our duties at the MC for today. We are very pleased to be here with you all. Thank you very much for your kind cooperation, and we wish you all a pleasant day. Thank you very much, and goodbye.
Goodbye. Bye.
Tomorrow. See you.
See you. Thank you so much.
Recording stopped.